I have to invite the speakers come on the stage, and if there is any question, you can ask them.
Question, Marius. Thank you for coming. Thank you for your presentation. My question is about micropapillary thyroid cancer. You were conservative regarding the indications, the classic indication, low risk, but you will never find a micropapillary cancer in the middle of the lobe. It's difficult to find it. For thyroid cancer, micropapillary cancers that are located posteriorly, you must be prudent, so I share with you your vision. For micropapillary cancers which are very close to the capsule, but they do not invade it, there is no risk. If you burn the capsule, there is basically no risk. So having a safety ring around the micropapillary tumor, is possible. And I have another observation regarding the dimension, because 1 centimeter is not really the deadline of thermal ablation. Maybe could be 1.5 or 2. You can perform ablation, good ablations, even in tumors, in micropapillary tumors, which are more than 1 centimeter. And Lucrezio, an ancient Latin philosopher, said that natura non facit saltus. That means that the nature doesn't reason by centimeters. So, and another observation, my final observation, is that not multiple, but bifocal micropapillary cancers are being done. There are published data, and I did a few cases in only 1 session, and this could be another indication, provided that there is no lymph node metastasis.
Thank you for those comments, Roberto. So I have tried to keep things as clean and didactical as possible, but obviously the field doesn't stay within a pre-specified category. So I agree with you that 1 centimeter is not a biological cutoff point. There's no reason for 9 millimeters to be different than 11 millimeters. But I think we all agree that the category of low risk doesn't have a higher end than maybe 1.5. However, the way we approach these nodules is to discuss with our colleagues in interventional radiology. So we at Mayo have the practice of thermal ablation performed by interventional radiology. We have a discussion with the patient. We open the door as endocrinologists. We feel that this is a good approach. And then we discuss the technical aspects with our colleagues in interventional radiology. How do they feel about the margin? As you said, can we hydrodissect it? Can we get to the capsule and still stay away from important structures? And we have gone up to 1.4 centimeters. But I don't think that I would make that as a rule that we should go there. We feel very comfortable up to 10 millimeters. And I think you made a number of other comments, but in the interest of the other question askers, I'll stop here.
So, Marius, congratulations about your presentation, great presentation. 2 points, 2 questions. Concerning about the micropapillary PTMC, you showed in your presentation about indication for treatment for 1 PTC. That's the main indication, of course. But under special situations, we see in literature review, we could apply, if well localized, for 2, even more. I don't like more, but I had a case, particularly a case of a woman, 42 years, by treatment to get pregnant, and she doesn't want to perform surgery anyway because of her treatment. And then we treated one with 0.6, another with 0.7, and she's okay. The 2 lesions disappeared, and she's in a nice follow-up. I would like to know your opinion about this. And just another, concerning about the cystic lesions, we more and more are trying to perform for predominantly cystic lesions with a more huge solid component associated, combined therapy, and with nice results. I would like to hear about you.
Those are valid points, and I think Roberto brought up the same issue. This is the way I look at the fact that there are synchronous multiple PTCs. It's probably likely that there's a genetic predisposition for those patients, which means it's probably likely that whatever thyroid parenchyma we are not ablating is at risk of subsequent thyroid cancers. So certainly some patients will not accept surgery no matter what the consequences are. And in that case, I don't think it's wrong to open the door to RFA. We've discussed actually at least 2 such cases that I recall. But what I caution them is the reason we're seeing multiple small papillary thyroid cancer might be a hint that you will have in the contralateral lobe or in the same lobe lesions to develop in the future. So once we do the ablations and the ablated area is bigger, it might be a challenge to monitor by ultrasound. It's not impossible, but I don't feel that everybody that has 1, 2, or 3 small PTCs should take the route of ablation. I think this discussion has to happen first. And second, about the combination, absolutely. That's what my colleagues in interventional radiology have suggested a few weeks ago when we had about 75% cystic and 25% solid nodule. Said, well, you know, we could do RFA for the solid component and do atherosclerosis for the rest, and the results we're yet to see long term, but short term looks very good. Yeah, I appreciate that comment.
Hi. Sigfrido Miracle from Mexico. Dr. Marius, for the patients that you are deciding the micropapillary thyroid cancer, that you are deciding if they should go ablated or no because of the risk, would you recommend doing molecular markers in them and to avoid the BRAF V600s, or doesn't this sound like a normal practice?
Yeah. And there's a challenge there because we're talking about cytology. So the diagnosis on cytology will rely just on microscopy. We do not routinely perform genetic testing on clear cytology. If it were an indeterminate nodule, then we would get genetic markers. So I'm not sure that a micro PTC of 8 millimeters that has a BRAF mutation would require a different management, would require surgery. I don't have the answer to that, but I don't think the literature, and there are large series that my colleagues will talk about in the coming day or so, none of these series has suggested that there's a subgroup of micro PTC that performs badly. So I don't think the genetic makeup seems to indicate that we should look for the BRAF 600E.
Mil Žarković, Faculty of Medicine, Belgrade. There's a thing that bothers me a little bit regarding thyroid systems. Why should we do a biopsy on thyroid 5? Because post-test probability is between 60 and 80%. Using simple Bayesian statistics, you cannot drop post-test probability enough. So why don't we go straight to the treatment for those group of patients?
Yes, I think that in the future you can decide to go to the surgery if there is a TRAS 5, I think, yes. Now I don't feel to make this, I prefer to make a biopsy for this reason, but I agree.
So you don't think that you should go to biopsy, but go to the surgery with TRAS 5?
But I've read some paper that in the future it's impossible to send directly to the surgery. I've read TRAS 5.
Yeah.
But now I am afraid to make this in Italy. I think it's dangerous to decide to make this. But I think that with the TRAS is a popular when the TRAS 5. I think that if you put other system, also elastosonography, for example, or also CEOs. And usually when I make TIRADS, CEOs, and elastosonography share a strain, I am sure that is a papillary.
Thank you.
Less than 15 minutes for panel discussion. And we start now the panel discussion. You can ask any question from the speakers. Thank you.
Yes, good morning. I have one comment and one question. The comment that in my practice, I use polydecanol instead of ethanol for sclerosing material for thyroid cyst. And actually we published data about that using polydecanol nearly painless, no flushing, no headache, no hoarseness of voice, nothing. It is a substance which is used by our colleagues in vascular surgery for varicose vein as a sclerosing substance. So I need to hear if you have an experience with this material. And the second, this is a comment only also. The second question is, I do routine neck scan to my patients in my clinic. One case, I would want to have your experience about it. Accidentally, there is nothing, no nodules inside the thyroid gland, but I found suspicious lymph node. Then I took a fine needle and it was metastatic papillary carcinoma. So I want to ask, is there any rule for thermal ablation in such case? If we have only metastatic lymph node, for this patient I referred it to surgery, and it was 2 millimeter papillary thyroid carcinoma, first presented by lymph node metastasis. So I want to ask if there is any rule for thermal ablation for such case.
So to take your first question as to the available material for atherosclerosis, we're using 95, as I said, a 95 alcohol-proof ethanol. I'm not familiar with other products that might be used, but if you have good success, I would continue what I'm doing. Second aspect, I think that's more challenging. So thermal ablation, if you have metastatic lymph nodes, you already know that that cancer has a behavior that it's not the typical one described by the low-risk carcinomas, which are 92 to 95% stability at 10 years out without lymph node involvement. So you already have detected a cancer with lymph node involvement, and you actually described that there was a problem identifying the primary. It turned out only on final pathology after thyroidectomy. So you do not have a target for ablation, and you have a more aggressive cancer. I would not open the door for thermal ablation in that particular case.
No, I mean ablation of this lymph node. Would you ablate it, or you should
Well,
refer for thyroidectomy?
I think that you need to deal with the primary and with the lymph node. So if you're ablating the lymph node, you're missing the source of the metastatic disease, which doesn't seem like it would add up to your patient. So I would ask my colleagues in surgery to help.
Yes.
And actually even identifying, is it ipsilateral? Likely, but sometimes we can find it contralateral. So if you finish a lobectomy and there's no disease identified, I think the question is, do we need a completion? And maybe some of our surgical colleagues want to chime in on that.
We are doing ethanol ablation with only alcohol, so no experience with other products. And we are just starting only with benign nodules, so no experience on cancer or on other kind of procedures on nodules, so only benign nodules actually. And one comment I have is, I think in this discussion, the team is very important. And if you rely on your endocrinologist and then on your pathologist for the results of FNA, so you are doing the procedure like an interventional radiologist, and in the end you follow up the patients in a group and in a multidisciplinary team. So I think this is the best way to treat this kind of patients.
Hello, good morning everybody. I am Hossein Chegini from Iran. I have some experience on RF ablation and have two questions. The first one from Professor Valcavi. We know about the isthmus nodules. Nodules in isthmus always are juxtacapsular because the isthmus is thin. For example, when you have a 9 millimeter nodules in isthmus and We know from the last that the nodules in isthmic region are more prone to be metastatic. I have some experience, and all of the patients are good after 3 years follow-up. But regarding to the discussion, do you ablate the isthmic nodules, for example, 8 millimeters, 9 millimeters, 10 millimeters or not? And the second question is about the FNA indications. Regarding to algorithms, AT algorithms, ACR thyroids, all says that the nodules below 10 millimeters are not indicated, even at high risk nodules, for example, Thyroid 5 nodules. But when we must discover the micronodules, micro PTC, we do that when we are more prone to the nodule to be metastatic. We FNA that. But in this algorithm and guidelines, there is no point about when we must do FNA biopsy from micronodules. Thank you.
As regards isthmic nodules, you can perform ablation on isthmic nodules according to their size, using less exposed tips, needles. So I'm aware that there are 3.8, this is the minimum exposure, so the risk of cutaneous burn is very low if you use low power with 3.8, which is less than 4 millimeters. And other exposures are available, like 5 millimeters or 7 millimeters. According to the size, if you perform RFA with these devices, you didn't get any risk. Or burn. Yeah, burn is the main risk for isthmic nodules, cutaneous burn.
The question is about the high-risk nodule in ultrasound. It's a category 5, and I think it's you need every time the sample with pathology to take some conduct, because sometimes, for example, the case the doctor showed about the alcohol treatment, after that the scar looks like a tumor, because the benign lesion after the scar, they can look like a tumor. I think in Thyroid 5 you need every time the pathology to take some conduct. I don't know what you think about.
So you're asking if we should have performed a biopsy on the thyroid cyst?
No. In any nodule.
In any nodule.
Any nodule, for example, they have indicate Thyroid 4 or 5. Okay, you need after could be to me could be clear it's a papillary, but sometimes this papillary is not papillary, especially in old colloid cyst. The evolution they looks like cancer sometimes. And in this case, after to take the conduct like for thermal ablation or surgery, you need the pathology. One hand is this one, and different kind of pathology, you have more or less risk for this lesion. And the other side could be a medullary or other kind of cancer too. What do you think about?
Okay, I'm not sure that I understood your question perfectly, but nevertheless, I do not send any patient to surgery without obtaining a cytological diagnosis. It might be that the risk based on ultrasound is 75, 80%. That means if I were to go straight to surgery, I would subject 20 to 25% of patients to go to surgery for a benign nodule. So 85%, even 90% doesn't mean 100%. In my mind, the cytological diagnosis is the gold standard for moving to the next step. And if we're ending up with a benign nodule, it might be ugly looking on ultrasound, and I might decide to repeat the ultrasound in 6 to 12 months because we do have false negatives. They are less than 1%, but they exist. So I might repeat the ultrasound more frequently, but I would not go to surgery.
And now the panel discussion is finished, and I'd like to thank you